Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Okay, welcome everyone to the Cracking Cancer podcast. This is a podcast series dedicated to increasing awareness about all things cancer, answering your questions, and raising money for cancer research. To learn more, visit crackingcancer.org, and please remember to like and subscribe. I'm your host, Dr. Kyle Concannon. I'm a medical oncologist at MD Anderson Cancer Center, and joining me today is Samantha Morell.
Hi, everyone. Samantha Morell. I have non-small cell lung cancer with a HER2 mutation, stage 4, and I'm coming here from the patient perspective. So good to be here, doctor.
Good to have you, as always, my partner in crime here. So today we're going to be talking about a topic that a lot of people, when they come into clinic and see me for the first time, it's something that they don't fully understand because it's really, really complicated. And that is, what is metastasis? What is that idea of metastatic disease? What does the term mean? What's biologically going on? And what implications does that have for treatment? And these are going to be broad strokes because every cancer is different. The terms are applied differently in different types of tumors. So this is getting a baseline level of understanding, but you definitely need to talk to your team, your oncologist, about how the different terms apply to your cancer or your loved one's situation. So first, I want to start by asking you, Samantha, when you were diagnosed, I'm curious as to what that term meant to you. What was some of the connotations or the initial perception when you heard that word?
So I always knew what that word meant to some degree in the generic kind of way of it being stage 4. Although now I'm finding that that's not necessarily the case for all cancers, but that was kind of my perception. When I first had a CT scan in the hospital, I had suspicious lesions in my liver and my lung, and they didn't know, A, if it was cancer, or B, if it was cancer, what cancer was it? But they knew that whatever was going on was in at least 2 places. And so I immediately was very, very concerned. No one ever said the word metastatic to me. In fact, I struggle even saying that word just because it's hard to say. But no one ever said that word to me. They just said things are happening in both organs and we need to figure it out. And what I found is that it seems to be in many cases when people have these scans because they have symptoms of XYZ reason, they have suspicious things going on in multiple places. And so no one, even if they suspect it being cancer, can tell you what type of cancer you might have because it's in multiple places, which makes it even more confusing because you're just in this dark hole of being like, okay, well, if it's likely cancer, it's in 2 places. I know that equals really bad. So that was my experience. And I don't think anyone has ever said metastasize to me throughout even like any of my doctor visits or diagnoses or anything, just that like it is in multiple places in your body. That means for lung cancer specifically, it's stage 4. And stage 4 means that you will be on medicine for the rest of your life. So that's kind of how it was portrayed to me in terms of like, this is what metastatic cancer means.
Yeah. Yeah. And I think I hear a lot of that too. And people associate, is it metastatic? Is it stage 4? Because these are the scary words. These are the words that mean, things are as risky as they get.
Yep.
I guess.
Yep.
And was that your sense when they see it in 2 locations and it was we assume this is well, you mentioned they weren't using the term metastatic,
No.
but you were, assuming stage 4, which is, the process had metastasized.
Yeah, I was assuming that. I don't think they were. Because I think that maybe they thought, oh, maybe one's cancer and one of the other organs isn't cancer, because I know sometimes that can happen too. So there was just a lot of misunderstanding. I mean, I remember going into my primary care physician literally as my app told me that it was confirmed I had non-small cell lung cancer. And even she was a little perplexed on like what stage I was at. It mentioned lungs and liver and lymph nodes, and like, I don't know. I don't think necessarily every doctor knows what that means and what staging that means. And so she was surprisingly positive on like, yeah, we don't actually know. Like maybe you'll be curable. And so she gave me like a weird sense of hope, which kind of irritated me because then I come to find out of like, oh, this really isn't good. And they did a biopsy on my liver, which confirmed non-small cell lung cancer. So then I was like, okay, well, then it's definitely cancer in my liver. And obviously the tumor in my lung is cancer. So that's how we got confirmation that the things in my liver were indeed non-small cell lung cancer, which is still so weird to wrap my head around, that like you're in a completely different organ and you have a biopsy and it comes back with a cancer that is from your lung. Like that's really hard to wrap your head around.
Yeah. And, functionally what that process is what it means to metastasize.
Right.
When a tumor starts in one area and it gains the ability to travel to a different area, that's what we mean when we say something has metastasized. And in your case, you had a tumor that started in the lung. We know that because we have these stains. We can do this testing in the laboratory. It says, yeah, this looks like lung cancer. It doesn't look like liver cancer. And we're pretty certain about that. And then when you biopsy the liver, well, this doesn't look like liver. This also looks like lung. And it actually looks like the same thing we biopsied earlier that was in the lung. So not only does it look like a lung cancer, it looks like your lung cancer that started here. So that adds another degree of certainty. But
I think that's what's confusing too, is because oftentimes people will say to me when I say like, oh, my main area of metastasis is my liver, they're like, oh, so you have lung cancer and liver cancer. And it's like, no. But there's this misconception that like the different organ it went to now has its own cancer.
You're totally right about that misconception. It's something that comes up all the time in clinic.
Yep.
And it's an issue of nomenclature, like how we use our terminology. So typically when we're talking about someone having a cancer of whatever organ, brain cancer, liver cancer, lung cancer, it means that cancer started there. So for many people with metastatic cancer of any type, lung, we'll use the example. If you have your primary tumor in the lung and it has spread to the liver or it has spread to the brain, we will say this is metastatic lung cancer to the brain or to the liver. We would not call those and a liver cancer or and a brain tumor. And that is a really confusing thing. And it's really confusing, particularly in the beginning when you're getting the diagnosis, because you don't know. I had a patient who did present with multiple cancers at once. This was a patient who had a finding on, a breast exam. They got their workup for breast cancer. It was a breast cancer. They felt it was high risk, so they scanned the body, and then they see a lung tumor. And then the assumption is that this is a breast cancer that has spread to the lung. So this would be metastatic breast cancer. And that has its own treatment types, which are different from local breast cancer. But that's why you go in and you do the biopsy, because sometimes you're wrong. And there's really, really dramatic implications for getting that wrong.
Massive.
Yeah.
Massive. And honestly, when I first read my CT scan, the very first one before I was diagnosed with the cancer or anything, and it talked about lesions in my liver and in my lung. Well, it was talking about 14 lesions in my liver and one lesion in my lung. And so I'm like, okay, well, it must have started in the liver, whatever it is, because there's 14 of them in there and there's one in my lung. Like, let's do the math here. Like, it doesn't make sense that it be the other way around. Like, my non-scientific opinion was like, there's no way it has to be coming from the liver then, because it must have been there a really long time. It managed to have 14 lesions be created and then it jumped to my lung. And it's like when you find out, no, it was actually from your lung that has one lesion. That's even more confusing to me, because you would think that the primary source would have more opportunity to have like multiples and grow and hang out before it starts going other places.
Yeah. And the confusing part about all of this is sometimes it does do that.
Yeah.
We have certain types of lung cancer, at least, and it's true in other cancers too, particularly liver, where you can have multiple tumors there. And it is from that organ. It spread locally.
Mm-hmm.
And, that's not always the case. I would say that's probably not the most common type of cancer spreading, but it's confusing. And that's why you need to do those extra studies, because any assumption you're going to make in the beginning is truly that. It's an assumption.
Yep.
In oncology, we have a saying that, tissue is the issue. You need to go in there and you need to confirm, because it's going to change how you do everything if that's a liver cancer or a lung cancer there.
Absolutely.
And, to your point of, I would think that the tumor that has, or the organ that has most tumor in it would be where it starts. So I think, let's unpack the biology a little bit here. So usually when a cancer starts, it starts from, we think, a single cell that becomes mutated or something. It becomes dysregulated in a way that instead of staying there and staying as that one cell, it starts to divide. And it goes from one cell to two cells to four cells, 4 to 8, and it keeps expanding. Along that process, sometimes errors happen. Errors in how it's replicating its DNA and how it's producing proteins. And proteins serve a lot of functions. One function is to interact with the cells around them and determine what that cell is going to do. So as the tumor is replicating in the lung, in this example, those tumor cells can get additional mutations and be dysregulated in a way that they stop acting like well-behaved lung cells. And once that happens, they get some additional, I guess, we'll call them privileges in the body, in that they're not following the rules. One of them is they get the ability to get into the bloodstream, which this doesn't usually happen. You don't have a lot of examples where in a healthy individual, one organ tissue just lands in a different organ and hangs out there. Like, you don't see that.
Yeah, it's wild.
Yeah. So this is a very unique thing, and it's disobeying a lot of rules. But that's not it. Once it gets into the bloodstream, it has to circulate through the body and survive that. It has to land somewhere, get back out of the bloodstream into that organ. And then it has to say, okay, usually I like to survive in my lung environment or wherever it came from, but now I'm going to do okay surviving here. And that's also a unique adaptation. So it has to disobey a lot of rules in order to be metastatic. So a lot of people will ask, how long did I have this primary tumor before it spread?
Mm-hmm.
If someone's diagnosed with metastatic disease. And the reality is we just don't know. We don't know how long it takes for that primary tumor to develop the ability to do those things. And this is where a lot of this isn't fair. Some people will have a really small tumor that develop the ability to go through the body and grow in different organs. And some people will have a very, very large tumor that never gained that ability.
Yep.
And it just doesn't, there's no sensibility behind that. It's just unfair.
It very much is. And for the audience out there, my primary tumor was just over 2 centimeters, which I found out today is essentially the size of a peanut. And that's so small. And I'm like, how can that tiny peanut sized thing do so much harm in my body? And it almost makes it more aggravating because if I had like a grapefruit sized tumor, it would make more sense to me that it would do what it was doing. But to be that small and cause that much disruption is kind of crazy to me. And then I will say I'm also mad at my liver personally because it accepted that metastasis. And correct me if I'm wrong here, like there's a level of wherever it's going to metastasize, that organ or other body part has to accept that default, so to speak, and let it grow and be in that environment as well, right?
Well, there are certainly immune populations in, like, your immune cells and your immune system has a role
Right.
in identifying things that are abnormal and removing them. It knows the things that the cells in your body should and shouldn't be presenting.
Mm-hmm.
Your cells have, each cell, if you took it out, it has things on its cell surface that identify it as, I'm a normal lung cell, don't kill me. When those things get messed up, your immune system can often tell. And people frequently make mutated cells all the time, and your immune system does clear them.
Right.
So when it goes throughout the bloodstream and it goes somewhere else, the native immune system doesn't identify this as abnormal. And there's a myriad of reasons why, we think. But it does have to pass that test.
Right.
So yeah, that's another failure of the body to protect itself against this error.
And that's what I keep reminding myself personally is it's not one thing that my body did wrong. It had to be literally a perfect storm of a multitude of different things in order for this to happen. And so then I'm less mad at my body because I'm like, okay, well, I guess it is what it is. But like, if it was one thing, I would probably fixate on it a lot and be like, why the hell didn't you do this? But it seems like such a complex perfect storm, like I said, that had to occur. And it's just, in some cases, just really bad luck.
Yeah, I think that's often what it boils down to.
Yeah.
Is we have factors that will correlate with a tumor's ability to spread. And that's what the staging system is really based around. And we'll talk a little more about that. But generally speaking, if a tumor is bigger, if it has higher risk mutations that we know are associated with worse outcomes, meaning its ability to spread and cause damage, those tend to be the ones that will spread more often. But there's no rule here. This is inherently unfair. And when many people are newly diagnosed with a tumor, there's really no way to know how long you've had it. We can speculate, but there's no way for us to know. So I think that makes it also really challenging. And if you're trying to find reason or make sense out of it, we can only go so far. There's a lot we don't know.
Absolutely. Do you know the science behind why certain cancers like certain parts of the body over others? Like, is there, because we know that, right? That, lung cancer, as an example, loves the brain, loves the liver, bones, and other organs I might not be aware of. And the same for breast cancer. But like, why is that?
Yeah, that's a whole area of study that, people look into because you're right. Not only does a given tumor have a likelihood of going to certain places, and another tumor has a different set of places it likes to go to. But even sometimes if you'll take a tumor and you'll say, oh, if it has this mutation or that mutation, that might change where it tends to go. And the reality for me is I don't know the molecular detail of what are the changes that tumor has, which makes it happier in bone than it would be in the liver, or happier in the brain than it would be wherever. But there's an interaction there. That tumor cell does have to do that process we described. It has to land in a bone, and it has to be able to grow, and it has to be able to signal to the things around it that it's okay, don't kill me. And that is a therapeutic vulnerability. Like, that's something that we will likely at some point, hopefully soon, have the ability to target. And hopefully for people working on this, there are some breakthroughs soon, because if you had the ability to stop a tumor from spreading, then it would be significantly less of a problem. We can manage local tumors fairly well, but it's once they escape, that's when those are the tumors that tend to kill people. And maybe now this is a good time to get into the staging, because we want to talk about what that means and how that plays into this whole concept of metastatic disease or metastasis. And when people think metastatic disease, at least when they've talked to me, they usually think stage 4. And they know stage 4 is the bad one. And that's true. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.